What we're going to be going over tonight is pediatric stroke. I want to take a special moment to thank Dr. Anjali Subswamy and Dr. Rachel Turi for their help with this project and continuing to move forward with pediatric stroke and the advances of that thereof. Also, thanks to Child Ready for all things pediatric and being able to continue to educate healthcare providers on all different issues. Now, as far as our objectives tonight, first is to become aware that pediatrics do have strokes. They have ischemic strokes as well as hemorrhagic strokes. The next thing is to recognize our populations that are at risk, how they present, and our interventions pertaining to both pre and in-hospital interventions. Now, real quick, I'll start with a case study, and this is a time when I first was able to realize that there is a population of pediatrics that do have strokes, and what it was several years ago I was working in the pediatric ER. A teenage male came into a rural facility with decreased level of consciousness and kind of this continuous seizure activity. What happened was they did a CT scan on this patient, and at the time nothing presented as being abnormal, but he continued to have this altered mental status, this seizure activity, so they decided to transport him to UNMH. Based on the weather conditions at the time and everything else that was going on, they decided to go ahead and transport this patient via ground. The patient continued to have this seizure activity throughout the transport through EMS, and the transport time was a little over 3 hours. On arrival at UNMH, still continued to have this activity. They went ahead and did their workup, provided their intervention, started IVs, did a CT scan on this patient. The CT scan revealed abnormalities, so they went ahead and sent the patient for an MRI, which revealed he was having a massive stroke at the time. He was later transferred to PICU and ultimately resulted in having severe and ongoing deficits that will carry through with him the rest of his life. Now, as far as our prevalence, the incidence is between 2 and 13 cases kind of nationally for every 100,000 children. And there's been kind of an increased trend in the diagnosis of children having strokes. The big thing, there's not a lot of data, but to determine one way or the other on whether they are increasing or just the awareness of this pathology is helping healthcare providers diagnose it faster. But the big challenge is there's still massive delays in diagnosis, from anywhere from 15 hours to 3 months before some of these children are being diagnosed with stroke. So, and a lot of the interventions are time sensitive, so it's very important to take that into account. Now, down here on the lower right hand side of the slide, you can see it's called a reverse bell curve. Now, this doesn't actually correlate with any specific numbers, but it's more of a visual tool. And as we know, as people get older, their risk of stroke goes up. But what I found through reading is that pediatrics, and the younger the age of a pediatric, the higher likelihood that they will have a stroke or be at risk for a stroke. So on the far left is your neonatal population, which runs a typically very high risk. And then as people get older, the risk goes down until you hit the bottom right there with your middle-aged individuals, 25 to 45 years old. And then as it starts trending back upwards as people get older. Now, in terms of the numbers, this UNMH sees approximately 25,000 patients a year, and in the past 2 years, there have been a total of 8 pediatric stroke patients. And it's one of those interesting things. It's like when you buy a new vehicle or you paint your vehicle, you all of a sudden notice that everyone is driving the same vehicle or driving the same exact color of vehicle as you. So I started noticing this trend a lot more, and in the past 6 months I've taken care of 5 pediatric stroke patients, and I don't work in any of the neonatal populations, which have their own percentages. So it's kind of interesting that as time goes on, finding more and more of this. Now, the overall impact of how this affects these patients, you can see it carries a mortality rate, and then there's a monetary impact that affects these families. And most of all is their overall quality of life. Now, pediatric patients have the neuroplasticity to bounce back from a lot of injuries. But the thing is, too, this is when their brains are developing. And with that development, if there's damage with it, these impacts are forever lifelong. Now, I've kind of lumped these two, hemorrhagic and ischemic, into just these broad definitions. When I speak about hemorrhagic stroke, I'm not referring to hemorrhage associated with trauma. Now, with your trauma patients, this is always something you want to consider, but for pediatric stroke in this setting, we're talking about different pathologies and risk factors, which I'll cover later. Another interesting thing that I found is, unlike in adults, pediatric patients have a lot higher incidence of hemorrhagic stroke. Anywhere between 45 and 55% of your pediatric stroke patients will have a hemorrhage. And so the big thing with it is, in adults, close to 85% of their strokes will be through ischemic. Pediatrics it can go one way or the other, with almost a 50-50 split down the middle. That was kind of fun. For my ischemic stroke slide, so my 5th slide in, I've managed to contradict myself, but I left it. So through the definition is diminished or no blood flow to a focal location of the brain, generating a neurologic deficit. But the thing is, as far as presentation, 85% of your pediatric patients will not readily present with neurologic deficits. So it's not going to be something that readily jumps out and you're like, this is what's going on with them. And it takes a little bit more in-depth assessment. As far as risk factors, I kind of lumped them into 5 different categories. Ischemic stroke, and one of the big things pertaining to it is, with your cardiac disorders, it's either number 1 or number 2 as far as the biggest risk factors that affect this population. One example would be a septal defect of the heart. And so the heart isn't getting full contraction, and from that, there's not all the blood being pushed out. It stagnates and then clots, later to be pushed out as a thrombi into the bloodstream. Your neonates will be one of the largest populations affected from this. One, because this is where these heart defects are first noticed, and they are first affect, obviously, these children. Another thing that carries with it is your surgical interventions, particularly with your heart surgery, but as well as with any surgeries. There's the fact that these patients carry a high acuity, and then on top of which your neurologic assessment will be impacted due to sedation. So it's one of the things where they can be affected, but you won't know until well after the sedation is worn off, which can be hours. To kind of couple with this, and just as I mentioned, any like long bone injuries, femur fractures, any surgical interventions carry the risk of carrying thrombi and generating your ischemic stroke. Now, as far as vascular alterations, there's a lot of, I found a lot of fancy names of different vascular alterations, but the big takeaway is that if there's any changes within the normal anatomy that impact the vessels and the blood flow, then you're going to generate ischemia. And also generate the possibility of hemorrhage. Any damage to the vasculature as well. So your cardiac kids, your renal kids, things that are putting high demand in association to high cardiac output are going to strain your vessel strength. And then pediatric patients with hydrocephalus have a risk for increased cerebral pressure and bleeding. Now, as far as your blood as far as your blood goes, there's the hereditary componencies of clotting. It's interesting. So there's a ×3 generational trend where if you have history of if they have history of stroke, DVTs, MIs, and PEs, multiple miscarriages, which a lot of our patient populations do have that hereditary component. As far as in adults, it puts your pediatric population at significantly increased risk. Now with adolescents, many of them are starting birth control, and coupled with that is a 2 to 2.5 times increase of risk for stroke that way due to clotting, and any smoking, substance abuse, anything along those lines. Now, this is a little farther down on my slide, but your sickle cell patients will be one of your biggest at-risk populations. Now, the reason why it's a little bit farther down is there's approximately 10 sickle cell patients in the entire state of New Mexico because their condition and with our altitude and our desert is not very conducive. But you could have one of these patients. You could have someone who is driving through, and one of the biggest things is being aware that due to problems with their coagulation, they are at risk, at profound risk for having a stroke. Any malignancies, so any cancers, also carry along inherent implications for stroke. Any malignancy within the brain itself is kind of self-explanatory, but it doesn't have to pertain to that. It can be any cancer throughout the body. The reason being is they generate different effects, either hypercoagulable or hyperviscous states within the blood, and then all the treatments that come along for cancer treatment, for the most part, are very taxing on the body and have similar effects. So being aware of this, that the majority of your cancer patients are at increased risk. Infections. Any infections as far as face, head, or neck are obviously, due to proximity, increase your risk of that happening. Meningitis also carries a percentage of stroke in up to 25% of their patient population. And pediatrics are regularly worked up for and diagnosed with meningitis as far as a disease. So being aware that there's a large percentage that have this complication that stem from it. Any massive inflammatory effects within the body. Going through it, there's tons and tons of diseases that can cause this, but systemic inflammation is something to take into consideration, and to be aware that if your patient is decreasing in some way or presenting like they're having stroke, this is a risk factor. And a final thought as far as risk factors, a lot of the diagnoses can and are attributed to idiopathic or unknown origin. You can have a perfectly healthy 16-year-old running around the soccer field or playing football and fall and begin having stroke symptoms and be diagnosed with such. One part of that is there needs to be more study on the field, but just being aware that if they don't have these underlying conditions, that doesn't mean that this isn't possible. Now, as far as your symptoms, I divided the two into ischemic and hemorrhagic. Being knowledgeable that the fact that they can be interchangeable. I divided the two because of the likelihood of presentation, but you can have hemorrhagic symptoms in a patient that's having ischemic stroke and vice versa. So be aware of that. Now, as far as your unilateral weakness or your hemiparesis, it's really your smoking gun when it comes to a lot of presentation. You may be missing a lot of other, or there may not be the presentation of a lot of other things, but the one-sided weakness is something that's definitely been found in a lot of cases. Now, it may not be very acute and it may not be very profound. There was a case of a toddler who went into her primary care physician and had just some weakness and some decreased use on her affected upper extremity. She was assessed for a musculoskeletal injury, so x-rays were done. Nothing was found to be abnormal, so she was discharged home. The next morning, she was found to not only have decreased movement of her upper extremity, but now the lower extremity. And as far as you look as a timeline, this is a prolonged amount of time, but it wouldn't be something out of the normal for a child to injure their upper extremity and not use it. So it's one of those things to be aware of. If there's decreased use of one side or the other, it's a very strong indicator that they may be having a stroke. Now, as far as your seizure activity, there's no specific seizure activity that's been associated with stroke as seen thus far. It is another strong indicator, especially if they don't have a past medical history. So it's a recent onset of stroke in upwards of 50% of your population. Migraine, with both the teen and adult patients, shows that there's double the risk as far as having a stroke. And your focal neurologic deficits are another thing that will come down to your assessment as far as being able to discern. Using your knowledge of their developmental milestones. And another thing is, while parents can present as being overly worried, they spend almost all hours with their child, so they have a very strong understanding of what their baseline speech and how they present and how they act. So any changes in this, and if they say something isn't quite right, it's something to definitely listen to, assess, and move forward with. Now, as far as your hemorrhagic stroke, it has kind of the textbook worst of life pain as far as your headache. Now, with pediatrics, you have populations that can't tell you they're having the worst pain of their life and the worst headache of their life. But one thing that you can do in your assessment as far as your presentation, and something that I heard about early on when I started working in pediatrics, is the neurologic cry. And it's very different from how a child will normally cry. And when I heard this initially, I didn't think much of it. But it is something that's very different. One way that I've heard it be explained is kind of like a cat meowing repetitively. They'll be inconsolable. There's no amount of rocking back and forth or pacifier that will soothe these children. And so if they're presenting with as such, it's definitely something to generate concern. Once again, any changes in their mental status, however subtle, should be evaluated. Seizures as well. Now, one of the things that has been found with your seizure patients affected by stroke is they will have prolonged seizures and also prolonged seizure, prolonged seizure activity and prolonged postictal periods. Particularly prolonged postictal periods that can go on for hours, and a patient will be like, they're still postictal. Well, this would be a very strong indication that there's actually a change in level of consciousness and they're not just postictal. With nausea and vomiting, children are not new to throwing up, especially with your infants. But one of the things is uncontrollable and projectile vomiting. is something to be concerned about. Pupillary changes are a very late presentation and are usually coupled with some other listing of the presented signs and symptoms, and it's very concerning if they're having pupillary changes. Some of the things that don't readily affect children, and you can see down in the bottom, are your Cushing's triad, your textbook facial droop, and EKG changes that happen. These are very, very rare presentations in children. It doesn't mean that they don't happen, but just be aware that you're not going to get that sudden, okay, this is what's happening. Now, as far as your neonatal population, they're even more difficult, and they're also one of the highest at-risk populations. So once again, your focal seizures is definitely an indication. Patients that are lethargic, so lack of stimulation, generating a response, or decreased appetite is something to look out for. Neonates, they're still learning to breathe, so they can have periodic breathing. But one of the things, if they have apnea, and apnea lasting greater than 20 seconds, then this should prompt further investigation and generate concern. A floppy baby is never a good baby. You crying kids are good. You want them to be moving around. You want them to be active as much as possible. And then your fontanelles. Now, here I have bulging fontanelles, and bulging fontanelles is just a baseline indication for increase in intracranial pressure, but also as well as hemorrhage. One of the interesting things too, and then I don't have here, sunken fontanelles can be an indication for dehydration, and dehydration can lead to stroke. This is an at-risk population for this, so use that as an assessment tool and kind of differentiate as your patient presents. As far as your further assessment, so you have your FAST exam. I've also heard it referred to as the Cincinnati. It's a baseline to be able to run through and find what's going on with your patient based on what their facial, arms, and speech, as well as the time indications. With kids, once again, it's harder. So once again, using your developmental milestones, your knowledge. If you have children yourself and you're like, all right, this is what they were doing at this age, you can even utilize that as far as your knowledge base. Eliciting some of these responses may be more difficult. A good example, so your toddler isn't going to hold their arms out in front of them so you can evaluate their arm drift. But one of the things you can do is be tricky about it. So you can take your pen light and hold it out in front of them, and if they reach for it, you can be able to elicit that response. If you hold them as a healthcare provider, they're going to want to reach for their parents. So things like that, you may have to change your approach a little bit, but being creative with that will be able to give you an idea on what's going on. One of the other most single important things as far as this, and particularly on this side, is your time. And you want your patients to last normal. I've seen a lot of situations where they go off of when the patient started presenting. But a very easy example is you have your patient, they eat dinner, they brush their teeth, and they go to bed. And then they're found in the middle of the night seizing in the bathroom floor. Or they come downstairs and they have left-sided weakness. It's one of the things where, especially based on the interventions, you want to get their last known normal, and that's what the interventions are based on, not when they start presenting with abnormalities. Now you can use your presentation to kind of differentiate an area of the brain that's being affected. In this case, so any damage to one side or the other typically has what's called an ipsilateral, so an opposite effect on the other side. So in the case of your left hemisphere being affected right here, you'll have, since it deals predominantly with speech, you'll have changes in speech, wrong words, but if it affecting the opposite side, you'll have right-sided droop and right-sided weakness or deficits. similar with the opposite effect on the right hand side. So they'll have correct speech, but their left side will then have the deficits. Brainstem, you'll get bilateral throughout. And one of the other interesting things with your cerebellum and your hemorrhage, there's little indications here. So with your cerebellum, you have correct speech, no droop and no drift. Using the finger to nose or heel to shin in both pediatrics and adults can help reveal what's going on in this case. And with your hemorrhage, you may only have changes in speech and maybe a decrease in LOC, but no droop, no drift, and no deficits. I say this not to call in every pediatric stroke or as a stroke alert and if anything's going on with them, but being aware that their presentation can be very subtle and using your assessment techniques to figure out what's going on will be very important. Now, as far as our interventions, anyone who works in healthcare knows that covering your A, B's, and C's is paramount, and I will harp on this no longer. The next thing you want to progress to is your neuroprotective care. Now, the first thing here is there's this great debate, well, does the head of the bed need to be flat? Does it need to be at 30 degrees? Back and forth. Any range between 30 degrees to having the bed flat is appropriate, and taking appropriate measures for your neuroprotective care. The other thing that couples with this is your 2-year-old who's ornery and who wants to fight you and who wants to crawl all over everything. You may not be able to achieve that, and strapping them down is not going to help your situation at all. If you're using your car seat, this can help because they are strapped in. The thing with it too, though, you want to keep their head midline. Any shifts left or right is impeding or impacting your blood flow. So in a car seat, you want to kind of pat around them, for example, to be able to keep their head midline and to keep them in that anatomic position. As far as your blood sugars, the big thing is you want to avoid hypoglycemia, but you also want to avoid giving IV glucose. This generates fluid shifts and can also negatively impact cells. Now, if you have a patient who's profoundly hypoglycemic, then your life over limb intervention will be to give the glucose, but it's not something you want to readily give, and if you can give them alternate means to keep their sugars up, then this is something you want to do. As far as oxygen, and you want to keep them above 95%, and as well as if you're in the situation where you have to bag this patient, the emotions already run high on the basis that this is a pediatric patient. You don't want to overbag them. This is going to generate, once again, an increase in intracranial pressure by overbagging these patients. So normal ventilation is key. Pediatrics, any fluids, they're at risk for overload and as well as dehydration. So when administering fluids, just being aware of how much you're giving. Do they really need this amount of fluid? A good example is if you have a neonate, your 10 cc's used to flush to ensure that your IV is working. Well, this 10 cc's counts as a bolus, and do they really need that bolus is something you'd have to evaluate. As far as fever control, you can have issues with both infection as well as just overall damage. You want to try and control this as much as possible. And then your blood pressures, you don't want to treat your hypertension. Now I'll remark more on this here in a minute. But as far as additional interventions, a continued reassessment, as arduous as it may be, you'll notice changes in your patient's status. Something I quickly learned in pediatrics, and I got a re-experience the other day. I went to start an IV on a 21-month-old, and I had another nurse with me go in, and by the end of it, I realized that and wished that I had brought 2 more people in with me because she was fully competent and could be could be a pro in wrestling someday because of how much she fought, how wiggly she was. On kind of the same page as far as IV access is I've seen situations where people have hesitated to start IVs on pediatrics, whether for fear of missing, for making them cry, or for parents not being understanding that you're poking their child with needles. The thing is, you don't want to wait for a situation where your patient begins to decompensate and then you're having to fight with your airway and you're needing an IV access and you're behind at that point. So taking the step and not being fearful of these interventions. Obtaining a good history can definitely dictate and expedite treatment, and then finally seizure control. Now in the hospital setting, there's a plethora of different medications that are used for seizure control. Primarily what I've seen a lot is Keppra is given to these patients. But in a pre-hospital setting, a majority of what is given are benzos. With your benzo administration, if your patient is actively seizing, that is your life threat, and you need to control their seizure, especially if they have this continued activity. But if it's one of those things where if they're not seizing, it shouldn't be given in kind of a prophylactic measure. The reason for this is, one, it'll skew your neuro exam, and then secondarily to that, it'll change your blood pressures and lower your blood pressures. Now the reason I speak about decreasing blood pressures and your avoidance for it is this thing called the ischemic penumbra. Now the basic idea of it is you have your obstruction, and you have in the dark area on the presentation, you have your area of cell death and ischemia. So that's your area of irreversible damage. However, your pressures and the pressure pushing against your obstruction there is perfusing this wider area of red and pink. And these cells are still salvageable, and even hours after the event. The thing is, if you lower their pressure, then there's no longer perfusion to those collateral vessels, and then your area of ischemia and death thereby increases the overall deficit and impact on these patients. Now, I know this is a busy slide, but it's kind of a quick cutout as far as the stroke algorithm that we have at UNMH. And it also will give kind of perspective as far as your timeline. So to start, we'll start on the upper left-hand side here. And so you have your patient presentation, and they have the deficit, they have the presentation of having a stroke. If they are under 4.5 hours and even under 24 hours, the goal would be to get them to where they could be treated for that stroke. If you're outside that time window, then depending on the facility and where you're at would be neurological consults and eventual transport. The other thing is, particularly in the area of EMS, you're not going to just transport every pediatric patient to your closest stroke facility. Many of your areas that you operate, it's rural New Mexico. So most protocols dictate that you transport to your closest appropriate facility, particularly in the case of stabilizing your patient. So it's one of those things where you take them to whatever facility is closest to you. They're stabilized there. If they fit the criteria, then they'll be transported to UNMH typically, depending on proximity as far as stroke center. Now, and then from there, they typically come in through the ER, and the big push, particularly in the 4.5 hour time frame, is to be able to administer TPA. It would be initially administered within the ER, and then later these patients are transferred to PICU for further stabilization and treatment. If they can fit the criteria for a thrombectomy, they once again come in through the ER. By activating the stroke alert, it also will either call them in or get the team ready, and they'll be able to generate their intervention there and then later move them to the PICU. The big thing here, and the big thing that readily became apparent to me, particularly if you're working in a rural setting, so you have your patient here and an unknown amount of time as far as their presentation. And then there's your response time to the scene, which can be anywhere 15 to 30 minutes depending on where you're at. And then you have your transport from scene. Once again, we can do 15 to 30 minutes as far as that goes. You take them to their closest appropriate facility. From there, they'll generate their interventions, which can be anywhere from, it could be an hour, it could be 3 hours, it could be more. And then there's your transport to UNMH. If weather's not permitting, then you go via ground. If you have flight, you can go that way. But once again, in that time range, you're looking at anywhere from an hour, it could be 3 hours, it could be more. So this 4.5 hour time window can very quickly be eaten up. And to generate positive outcomes with our patients, just being aware of this and being conscientious of your time and how much time you're spending on each individual aspect of their care. Now, as far as definitive diagnosis, as I've heard, is cold hard steel. So your gold standard is going to be MRI. This will give you the type of imaging where you can see what's going on and see what you need to do to help these patients. The thing with this, though, is an MRI can take anywhere from 30 minutes to an hour to get the type of imaging that you need. If your patient condition doesn't dictate it, if you don't have the capability to do it, there's certain aspects that may preclude you from that. So your next best available type of imaging would be your CT scan with angio. It can be done in a lot faster time frame and can indicate vessel impairment and thereby giving an idea on what's going on. As far as your treatment, like I said, the big push is to administer the TPA in that 4.5 hour window. Once again, it can be that window can be moved very quickly, especially depending when your patient's last known normal was. Secondarily to this, thrombectomy, there's a larger time window. You have typically a 24-hour time window. So from speaking with IR, this is where they do the Star Wars stuff, and they actually will go in and remove the obstruction manually. If it's a case where you have hemorrhage or just a massive amount of swelling, hemicrania is also indicated. Now, to kind of conclude with a final case study and an example, as a very similar patient presented to a rural facility. And one of the biggest, albeit differences with this facility, is recognized as an adult stroke facility, but came in with a similar presentation. A teenage male comes in, seizure activity, decreased level of consciousness. He was scanned and showed that he was having a stroke. The facility there then consulted with UNMH and made the decision to administer TPA there at their site, felt comfortable with doing as such. They administered the TPA and then transported the patient to UNMH for further treatment. The ultimate outcome with that patient was much better, with minimal deficits. And the biggest thing that this can be attributed to, each case is very different, but the big thing is getting that timely diagnosis and treatment will greatly change your patient's outcomes. Now, as far as our additional resources, for the full entirety of the UNMH stroke protocol, they have this website here. Under the search bar, under policies and procedures, you just type in pediatric stroke. It gives you a full idea on, one, the time frames, and then two, the different personnel and the different interventions that take place there. Next is the Child Ready program. Like I said at the beginning, continuing knowledge base and improving child safety throughout New Mexico. And then finally, as your NIH stroke protocol. They have one specifically designated for pediatric stroke. And in that, it's a very in-depth assessment, but with the pediatric one, there's a lot of questions in there changed to be able to elicit the assessment response that you want out of a child, to be able to evaluate if they have a deficit or not. So it's just an extra tool. Like I said, you still would want to keep your assessment basic, but it gives you small pointers on being able to extrapolate on that. At this point, I'd like to open up the floor to any questions.
So Kendall, can you just review the numbers again? Because it seems to me,
And we still have you on
the
camera.
prevalence, it seems to me that by my calculations, we have 4 times the national prevalence here in New Mexico, and that's not with all the reports. Could you just repeat those numbers again?
Yeah, so and like I said, it was hard to come up with exact numbers, especially because patients will be transported to UNM from outside. But within the ER, there's 25,000 patients seen per year, from my understanding. And then in the past 2 years, there's been 8 patients that have been seen here at UNMH, or taken care of, or have been taken care of. I know, especially from direct care of those patients, there have been a fair number of patients that have been transported from outside. So there may be some differences. Like you said, I was just taking an overall, like what is seen in the ER, but it may not reflect the actual basis as far as what the ratio here in New Mexico is.
Because you said like 10 to 13 per 100,000, right?
2 to 13, but yes.
2 to 13. So even at 13, by my calculations, if say there's 8 strokes in just our ER population of 50,000 in 2 years, so 25 a year. So 8 strokes, well, that'd be 16 strokes, I guess, for every 100,000.
Yeah.
And that's only in our one facility, not counting, and we probably only take care of about 30% of the kids in the state. And so it just seems to me that that's really underscores the importance of this information that you're giving. So that's cool. Good. Not good for the kids, but good for them. Could you clarify what you meant by when you said renal kids and under risks, and why, what that was about? I think you were talking about vascular damage.
Yeah, so these kids will have increased blood pressures due to decrease in renal function, generating higher stress in the vascular system, and thereby damage and increase the risk.
Okay, thanks. And then when you said migraines, you put them in people with migraines, or you put migraines in the risk category. But I didn't know if you were talking about, did you mean people with migraines are more at risk for stroke, or migraines might be a sign of stroke?
It's one of those things. It's an increased or an indication for risk. But then also, if there's sudden onset or sudden changes with their baseline, it's one of the things that can be a differentiating factor as far as signs and symptoms.
Got it. Catherine, how are we doing for time? Because I have more questions.
We're running a little bit over on time, but we did start a little bit late, and I don't think we've lost many to attendance, so I think we still have people available.
We have a couple questions too.
Oh, you do? Let's get
Well, we
there,
have
sir.
one. She says, how will this information continue to be shared across New Mexico? That was fabulous.
So that's kind of the big push, and what's happening right now is right now they've just come out with the stroke protocol within the UNMH system, and it's to the goal is to educate the providers within the system as far as what they need to do. As far as reach out to facilities and to individuals across the state, realistically, this was just a first step, and taking platforms and seminars to continue this on is kind of the goal right now.
And just to springboard off of that, for the audience, do remember, and I don't know if we're in your local community or not, but with the Child Ready telehealth program, so we're building a virtual pediatric emergency department, and right now we have 13 facilities around New Mexico that are participating, and so this information will be spread across that telehealth network in an educational format, but that format also allows us to do on-site consultation by telehealth, and so we could help those local facilities, like one of the cases that Kendall presented with the teenager and getting the TPA, etc. Through the telehealth program, we can actually see the patient and do real-time consultation that way. So if we're not in your local institution in your community, you could certainly help us. We're always looking for pediatric and child-ready champions in the community to help us expand these services and resources to the kids in New Mexico.
That is a perfect way for me to start wrapping up this wonderful Child Ready session. We do, again, thank you for your patience in the beginning, and we deeply appreciate Kendall coming out and participating. This is invaluable to most of our community, so thank you very much. If you are interested in further information, you can send an email to hsc-childready@salud.unm.edu, and this presentation will be archived and available on child-ready.org in about a week or so, give or take. Joan has some magic she does behind the scenes to make that beginning part seem seamless. And again, thank you for participating. Once you log out, I believe we have a quick little survey that will be sent to you. Once you complete that, you'll get your CEs online. It'll be emailed to you. And if you have any questions, always available at that same email address. And we'll look forward to seeing you in April, where we have some presenters that may be coming from Lifeguard. We're going to try and work that one out a little bit better. And maybe even a follow-up from Kendall. Who knows where this is going to go.
Can you give the phone number also?
Oh, I could give my phone number out. That would be... I do answer my phone if you call me. And that number is 505-272-6024. Again, thank you so much. We appreciate your attendance, and have a wonderful rest of the week. Goodbye for now.
Bye.
Bye.